Hello and welcome to the CCO podcast. I'm your host, Robin Black. Today's episode features a discussion on PSA and AxSpa and is part of a larger educational program titled Case Challenges in Spondyloarthritis. Can you crack the code with advanced targeted therapies for patients with psoriatic arthritis and axial spondyloarthritis?
Hello, my name is Julia Swafford. I'm a PA rheumatology. Currently work in Bronson Battle Creek Rheumatology Specialist in Michigan. I've been in rheumatology and adult internal medicine since 2011, and then primarily rheumatology for the past 4 years. I'm the president of Society of PAs in Rheumatology and have a preference for treating inflammatory arthritis and osteoporosis. And then I'd like to also introduce Dr. Ogdie and pose a question to her and let her introduce herself. So what kind of classes of therapy do you typically use in patients with psoriatic arthritis and axial spondyloarthritis? And can you tell us a little bit about the newer class of therapy that are available?
Cool. Well, thanks, Julia. Nice to be with you here today. My name is Alexis Ogdie. I'm Associate Professor of Medicine and Epidemiology at Penn in Philadelphia, and I direct the Psoriatic Arthritis and Spondyloarthritis program at Penn. So we see almost exclusively PSA, AxSpa, and then some other inflammatory arthritis sometimes. In terms of newer therapies available, and maybe I'll just back up a little bit and actually start with the therapy landscape more broadly. So within PSA, which has kind of the largest bucket of therapies, we have our oral small molecules. That's the medicines like methotrexate, sulfasalazine, apremilast, for example. And then we have biologic therapies, including the TNF inhibitors. So we have those 5 that have been around for a long time. We have the interleukin-17 inhibitors. There we have secukinumab and ixekizumab, and our newest one is bimekizumab, so I'll circle back to that. We have the interleukin-23 inhibitors, so those include guselkumab and risankizumab, so it's newer-ish, I suppose. And then we have JAK inhibitors. That includes tofacitinib and upadacitinib. And then IL-12/23 inhibitor ustekinumab, which is kind of one of our older medications now, and abatacept CTLA-4 So among all of those, the only classes that we use for axial spondyloarthritis are the TNF inhibitors, IL-17 inhibitors, and JAK inhibitors. So not the oral small molecules, not the interleukin-23 inhibitors, for example. So if a patient has psoriatic arthritis and axial spondyloarthritis, we're going to focus on just those 3 classes. And then for our AxSpa patients, just those 3 classes. So your question was about what's new. And some of the newest therapies are bimekizumab is the most brand new for psoriatic arthritis and axial spondyloarthritis. That is an IL-17A and F inhibitor. So it differs from its counterparts in that it is A and F. So secukinumab and ixekizumab are just IL-17A inhibitors. You know, the thought was that if you block more IL-17, you get more effectiveness. And I think we saw that a bit in psoriasis. So the new medicine, bimekizumab, is better than secukinumab in a head-to-head trial for the skin. However, for the joints, there's no head-to-head trials. We don't even have side-by-side trials of the IL-17 inhibitors. But for all practical purposes, it really looks identical. Bimekizumab and then ixekizumab both had adalimumab comparator arms, or at least side-by-side arms, just reference arms, and they both match adalimumab. So we think they work pretty similarly for the joints. So we can come back to who you might use that in terms of other newer therapies. The interleukin-23 inhibitors aren't so new anymore, but I think a lot of rheumatologists that may not see a lot of psoriatic arthritis may not be using them as much. They happen to be now the kind of biggest drugs used in dermatology across the hallway. So a lot of our patients will come on those. And those are highly effective skin drugs, really nice, clean safety profile. They are slow for the joints. So they work well. And actually, we just saw at our most recent meeting that the interleukin-23 inhibitors really performed very similarly to a TNF inhibitor or an IL-17 inhibitor for the joints at 6 months. It's, what I always tell patients is it's going to take some time to get there. So that's one of the caveats with the interleukin-23 inhibitors. There's lots new coming, but maybe we can talk about emerging therapies later.
So as far as the JAK inhibitor and that class of medication, I feel like a lot of dermatology, at least in my area, are hesitant with the oral surveillance information that had come out. We use them very frequently in rheumatology. What's your hesitations in using that medication? What do you typically go through when you're discussing that with a patient?
Yeah, that's a great question. So JAK inhibitors are actually pretty commonly used in rheumatology. And you're right, dermatologists tend to be a little bit more skittish around side effects in particular and with any medicine, and therefore with the JAK inhibitors. I think that's changing over time, though, especially as they get used to using the medicines for atopic dermatitis. Some of the concern with the JAK inhibitors came after oral surveillance, a large randomized controlled trial that randomized patients to tofacitinib or a TNF inhibitor, adalimumab or etanercept, depending on what side of the ocean you were on. And in that trial, they found that patients on tofacitinib had numerically more cardiovascular events and new cancer diagnoses. And this was particularly true for patients who were 65 and up, who were smokers, or who had elevated cardiovascular risk. And all of these patients entering this trial also had at least one cardiovascular risk factor and were 55 and up and had RA. So they already had higher cardiovascular risk than the general population. So in general, the average patient with axial spondyloarthritis is generally in their 20s, 30s, 40s. The average patient with psoriatic arthritis is in their 30s, 40s, or 50s. So a lot of times they don't have those risk factors, even though there are large groups of them that obviously may, especially as they get older. But we can still use those medicines for those groups. The way I approach it is talk to them about the trial, tell them about what was a risk factor for one of those events, and talk about the fact that while there was numerically more, it was a small difference. So on average, the number needed to harm was around 500. So there's still pretty safe medicines. And obviously for those young people, a once-a-day oral medicine can be really helpful for adherence as opposed to injections if they're at college by themselves, for example. So I think it's a good option for many of our patients still.
I think also, too, you had mentioned some of our other therapies we use can take months to really start working, whereas the oral pills, we see a much quicker response typically, which patients seem to enjoy, as well as providers.
Exactly. And I think some of the other interesting things about it is if you have, a patient who has more eczematous type psoriasis, that the JAK inhibitors can be better for them. Palmopustular psoriasis can sometimes do a little bit better on a JAK inhibitor. So some of those subtypes the JAK inhibitors can be really helpful. And the psoriasis response in someone who's got really bad psoriasis may not be ideal. So you have to think about how bad is their skin disease.
And, I think all JAK inhibitors got lumped in under the class, but we know that some are a little bit more specific. And so I know they're doing real world monitoring of, abatacitinib, and are those differences accurate for all JAK inhibitors or specifically more the tofacitinib?
Yeah, my personal belief is that there is not a major difference among the JAK inhibitors. They all look the same in real world data. They all look the same in clinical trial data. It was really the big randomized control trial powered and set up for this question that was different. So there's a lot, there are different papers suggesting maybe there's a difference. I'm not so sure. So I counsel patients the same way.
Yeah, absolutely. Yeah, the warnings are still on for all of them. So I would agree with that. I think also interestingly, we know patients who have, axial spondyloarthritis, psoriatic arthritis, can have also comorbidities. So when you're thinking of a patient who may also have inflammatory bowel disease or uveitis, are there certain medications you prefer and certain ones you wouldn't initiate?
That's a great question. So with Crohn's versus UC, there are some differences in which therapies, for example, the TNF inhibitors. For Crohn's, it's adalimumab, infliximab, and certolizumab. For UC, it's adalimumab, infliximab, golimumab. And so I always remind people when I'm giving talks about therapy to make sure you look at the dose, look at the drug, make sure it matches which subtype of IBD they have. But yeah, in IBD, we are seeing a lot more interleukin-23 uptake and also a lot more, and 12/23, so ustekinumab as well as the JAK inhibitors. And again, particularly for those young people. And for IBD, again, check the dosing always, but they can use some higher doses of risankizumab and higher doses of upadacitinib, for example, even a loading dose of the tofacitinib. So work with your gastroenterologist on that. But I think that is nice to be able to use those drugs in the same way. The caveat is if the patient has axial disease, and especially if they have radiographic axial disease, you're going to want to go with a TNF or a JAK inhibitor. The 12/23 and 23 inhibitors may not be as helpful there. Non-radiographic disease is a little bit more difficult because patients with IBD often their axial disease can get better as their IBD gets better. So treating their IBD can be sufficient too. So that's a little bit of a trickier discussion.
Fair enough. And then particularly with uveitis, we're commonly not using etanercept in those particular patients.
Yeah, I often say that for uveitis, the TNFs trap with Crohn's and psoriasis. So again, adalimumab, infliximab, and certolizumab are the 3 TNFs for uveitis. There are some studies with golimumab also suggesting it potentially works. The IL-17 inhibitors, secukinumab and ixekizumab, probably not great for uveitis. There's some interesting data with bimekizumab that maybe that there's not as many flares, or I don't know though. I think that's still to be tested and doesn't quite make intuitive sense to me. And then the JAK inhibitors probably also work at least a little bit for uveitis. Again, not great data, just a small study with tofacitinib, but at least some options out there. Methotrexate can work for uveitis sometimes too.
Absolutely. Yep. And then as we're talking about the newer medication, the bizakimumab, can you talk all about the suicidal ideation warning that is on that label?
Yeah, that is a great question. So just to give a little history behind the suicidal ideation component, back about 8 to 10 years ago, brodalumab was being developed for psoriasis. And this is an IL-17 receptor blocker. And that drug is approved for psoriasis, but only can be prescribed by a dermatologist who's been trained in the REMS program, because they found a number of additional suicidal ideation and suicide attempts in the treatment arm compared to placebo. And it was like 6 out of 4,000 people in that study, but still enough to raise some questions. So one of the things we know is that psoriasis itself and psoriatic arthritis and axial spondyloarthritis are associated with higher prevalence of depression and anxiety and suicidal ideation. Actually, one study we did in the UK, patients with psoriatic arthritis are 3 times more likely than the general population to have a suicide attempt. So this is a population that we have to be very careful with and counsel and screen for depression and anxiety. So in studies moving forward, they then required that you measure depression, especially in interleukin-17 inhibitors. They've done a lot of digging in the secukinumab data and in the ixekizumab data and didn't really see this increased risk for suicidal ideation. It would, in apremilast, it also has a warning for depression. So we have another one of our drugs that has that. Bimekizumab, they did find some more people in the PSA and in the psoriasis trials, not in PSA and AxSpA trials, but in the psoriasis trial, there were a number of people who were marking that they had suicidal ideation, which is one of the questions on the PHQ-9. And so, one of the depression measures they used had one question. And on that question, there were more people marking that. So that was interesting. And then it's still a very, very low risk, lower than across most of our diseases, but it's something that should be counseled about. And I've seen it a lot more in my clinical practice with all kinds of drugs, including TNF inhibitors, JAK, and probably one of every kind of drug by now. And what I now counsel patients is, if you have depression, first of all, I'm asking about that. I'm asking about suicidal ideation. These medicines are also almost like starting an SSRI, where you're giving people a little bit of activation energy. So they start to have more energy and feel a little better, and they can sometimes act on those thoughts if they're present. So I think regardless of what drug, it's important to screen for these things and talk about depression, anxiety, suicidal ideation. But this drug, bimekizumab, actually has that warning. And again, in the AxSpA and PSA trials, there was no difference and it was very low rate. But in some of the psoriasis trials, it was there. So given that this mechanism is maybe similar to brodalumab, it may be a drug effect, but it certainly can happen with any one of our therapies.
Thank you. That's much appreciated, because I think people will start reading then, be concerned. So I completely agree, asking that irregardless of medication choice, we know it's linked with the disease itself, and being aware of that. Do you think it's a good transition? Are there other things outside of pharmaceuticals that you recommend for patients with axial disease that can help them?
Yeah. Well, so number one is physical therapy. Actually, that's a key part of the guidelines. It's missed all the time. I can't tell you how many people I get with refractory AxSpA who've been through many different therapies and they've never been to physical therapy before. So that's always number one for me. And part of that is that if you have mechanical back pain, that's just going to make it seem like your AxSpA symptoms are present. And you need to be able to separate out the 2 different types of symptoms. And everybody gets back pain, including our AxSpA patients. So sometimes it's really not the AxSpA, it's a disc herniation. So, and sometimes it's not obvious to patients what's what. So physical therapy is important. core strength is what's going to hold up the back. It's not just doing a course of physical therapy, it's then continuing the core strengthening throughout the course of their life. It's like part of the medicine. So that's number one. Number two is emotional well-being. So we've kind of talked about depression and anxiety and making sure that those are things that are being dealt with. There's some nice studies in AXSPA that have demonstrated that if someone has mild, moderate, or severe depression or anxiety, the likelihood of them getting to remission is low. And it's increasing if there's a nice dose effect there of the depression or anxiety. And I think, again, this is something we see all the time in clinical practice. There's this nice paper by Stephen Zhao, like just perfectly shows this. So it's important to have the depression and anxiety dealt with. One of the other things is a disease that happens to lots of young people, and they have kids at home and they're trying to function. So occupational therapy can be helpful for that. Again, just regular talk therapy to figure out how does living with this disease look, or what can I do to make daily life activities easier. And sometimes that's about overcoming previous tendencies and creating change. And that's really hard for people. Pain management. So we have a high prevalence of fibromyalgia in patients with AXSPA. It's about somewhere between 10-30%, depending on what study you look at. So things like amitriptyline or duloxetine or gabapentin can help with sleep and managing the fibromyalgia symptoms. And again, if you don't point out that this is different than their AXSPA and that this is chronic pain or fibromyalgia or whatever terms you like to use, that's just going to keep getting worse and you're going to go through lots of therapies and cycles. So it's really important to help people pull those symptoms apart. So I think those are some of the big ones. Healthy eating is one that lots of our patients ask about. We just finished a dietary trial in psoriatic arthritis. We haven't done this in AXSPA, but I think generally a lot of those things are similar. So we haven't finished analyzing the study yet, but one of the things that we heard from our patients when they came back is that removing sugar was really important for them. And so a lot of people identified the highly processed foods and especially, simple sugars as a problem.
Yeah, that makes sense. I sometimes think about diagnosing somebody with a chronic disease, especially that's painful, is that they're grieving the life they thought they would have. So especially these young people trying to go through those stages of grief and talking with somebody. And it's helpful if they can have group support, but sometimes in our communities that are more rural, that's difficult to find. So that's excellent advice. I agree that exercise should continue lifelong. So in speaking in patients that may have other comorbidities, so when we think about patients who may have congestive heart failure, are there things we're looking at avoiding and having that conversation with patients?
Yeah. So congestive heart failure, we don't want to do an NSAID. That's number one. And that's always hard because sometimes it feels like it kind of takes the one of our major tools away. And then the TNF inhibitors we're going to avoid as well, because especially in class 3 and 4 heart failure, it could make it worse. I think in general, it's not a big problem, but we have so many other options now. It's better to avoid them. Now, on the other hand, the JAK inhibitors, not ideal either if they have heart disease already. So even though it's congestive heart failure, there may be underlying coronary artery disease. So you're probably going to avoid that as well.
When you're talking with a patient, I think the question of having them involved in their treatment option comes up, and that's becoming, I think, more and more prevalent. Even 13 years ago, we were still kind of in the concept of, this is what I like and this is what you should do. How would you define and how do you use a combined decision-making with the patient?
We actually created a shared decision-making tool for psoriasis and psoriatic arthritis. And it is very complicated because there's so many different options. So as a part of this tool, we worked with patients to design it. And so we have the list of different therapies that they could read about them if we wanted to point them to one. We also have a questionnaire that takes them through their symptoms, where their disease is located, what therapies they've had before, what type features of the disease they have. And then it'll give them green, yellow, and red different sets of therapies so they could read about those in advance of their appointment. There's pieces about flare and how to manage a flare and things like that. So our idea was that the more we would send this to patients in advance, the more educated they would feel when they come in to have a discussion about things. But interestingly enough, while I think that is helpful, we've kind of reverted a lot to paper again. And because there is something nice about looking at a piece of paper in front with a patient and circling or crossing things out. So my own shared decision-making tool is I have a 2-sided piece of paper that has all the different therapy groups, and it has all the different risks, things we're going to counsel about, and how it's given, subcutaneous or IV or oral, and the dosing regimen, all that kind of stuff. And then I can cross out the ones they've had. I can circle the ones that I think are options. I briefly step through them, and then we kind of talk about what they want to talk about. And on that same piece of paper is all the non-pharmacologic stuff so that I can quickly point to, obesity is a problem for our patients with psoriatic arthritis in particular. And we know that therapies just don't last as long in people who are obese, and that weight loss has at least as much power as switching to a new therapy. So, some of these things it's easier to talk about when it's literally visually in front of you. You can operate on it. So those are some things that I do in clinic. Also, for the fibromyalgia component, or kind of talking about the wellness aspects, I have another piece of paper that actually I don't print anymore. I just draw because sometimes it's more effective. I draw a circle, and then I put like a lot of the pieces on the circle, like pain, fatigue, sleep, whether it be like core strengthening or other things that need to happen, and talk about how the depression, anxiety, stress, how all operate together. And we have to kind of address all of them because we only address one piece, like just give you a medicine for the arthritis. We don't lift the rest up. And so the rest stays exactly where it's at. So I've found that to be more effective with drawing it out and writing the things on there that are specific to the patient. And then again, it just helps our conversation as we talk through which are the pieces that I should tackle today, or what should we tackle today.
I think that's a great idea. You have not only the visual, but the auditory of talking about that, because it's hard for patients to grasp everything as you're just reeling off all the potential risks and side effects. So yeah, that sounds amazing. I bet patients appreciate that. I just wanted to touch base. You had mentioned, sometimes they'll use methotrexate for uveitis. That we do that commonly in rheumatology as well. In fact, sometimes we get a uveitis consult and they don't have, an axial disease with it, but we continue to help manage with ophthalmology. Is there any other case where somebody has a axial spondyloarthritis where you would potentially use a DMARD, like in combination with our other therapies, our biologics and small molecules?
Yeah, in general, the oral small molecules are not really all that effective for the spine, but they can be effective for the peripheral arthritis. So if the patient has, a good amount of peripheral arthritis, sulfasalazine remains the kind of oral small molecule for that. Methotrexate is not included in the AXPA guidelines at all, but it is definitely an option for that patient who has more significant peripheral arthritis. The other place I often use it is in the patient with infliximab. If I even just use it in a low dose so that we can prolong the life of the drug. There's not a lot of studies about that in AXPA or PSA. We actually did publish one examining use of oral therapies in the 3 diseases, PSA, AXPA, and RA, and found that it does prolong the life of therapies still, even if it's sulfasalazine, in patients with AXPA. So there may be some rationale for using it that way. But in general, in AXPA, most of the time we're going to use in a monotherapy that's a biologic. But again, with peripheral arthritis, sulfasalazine can be helpful. Sadly, I see a lot of people, again, that have been diagnosed by a rheumatologist with AXPA, and they come to me on methotrexate. And I'm like, the methotrexate is not an AXPA drug. It's just not going to do anything for the axial skeleton.
Yeah, no, I appreciate that. We see that sometimes here as well, and then can understand why a patient may not be getting better. I think people also enjoy kind of hearing about some case studies. Is there any particular patients that you've had recently that have been challenging or that have had maybe different outcomes that you expected, and how you handled that?
Yeah, that's a great question. I think the most challenging patients for us, so we have in our room clinic, there's 4 of us that do SPA, and 1 is a nurse practitioner, and then 3 of us that are MDs. And the common cases that we end up talking about the most are people who have DISH, for example, diffuse idiopathic skeletal hyperostosis, can often look very similar to AXPA, similar to like the way erosive OA looks a lot like PSA sometimes. And it's just hard to distinguish the two. My kind of pearl there is make sure you're the one looking at the images, get used to looking at the radiographs of the SI joints and the hands. Obviously, we all pretty comfortable with hands, but and then the MRIs of the sacrum so that you're really looking for that. So you can still see stuff in the pelvis and in DISH. So, but if they're over the age of 50, really question whether or not this is AXPA at all. And then the other ones are the people that have been through, that you think may have AXPA, and maybe they had something on their MRI, but it wasn't quite clear. We know MRI is not a great diagnostic tool. It can be helpful when it's positive, but sometimes it's not. And sometimes it's not accurate. There's many things that can make it inaccurate, like running, for example. Anyway, so those ones where they have a little bit of imaging stuff, but they're not responding to any therapies, that's really hard too, because you're like, is it not? I don't know. So, and then you're trying to talk with the patient about whether or not they have the diagnosis and they're confused. So I think those are some of the most challenging to manage.
Yeah, no, I think that's great. And huge tool for everybody of saying, if I put somebody on a medication or a treatment plan and people aren't responding and giving it enough time to respond as well, do we have the right diagnosis? Do we need to reassess or change medication? But I think that happens so commonly in rheumatology, and that's hard. We want to be, correct and accurate. And so taking away a little bit of our ego and saying maybe this isn't correct is absolutely important.
Yeah, I always say in AxSpa that, when I was a medical student rounding with the rheumatology team the first time, they said this is like one of the most humble of specialties because we can be wrong all the time and you don't know. So I'm very cautious with patients about AxSpa saying, I think this is it, or saying these are the reasons that I think this is what's going on, and making sure that I am conveying that there is always uncertainty in everything. And so most patients want certainty, but actually when they hear you being uncertain and open and clear about it, it actually creates more trust. So I just am always cautious about that with inflammatory arthritis in general.
Yeah, no, I think that'll help give patients reassurance and understand what to expect up front. All right. Is there anything else particularly you wanted to address with the axial spondyloarthritis, or particularly psoriatic affecting the axial spine?
I think the one thing is getting the right imaging and making sure that you're able to look at it. So SI joints are the money shot. You can get other aspects of the spine, but you can be misled on other aspects of the spine. But the money shot is really the sacrum. Both for AxSpa and for psoriatic axial disease. There's a very cool study just presented at EULAR that's not published yet, but looking at what is axial what is axial PSA, and the imaging is really so important there in terms of labeling it as PSA or axial PSA. So sacrum, SI joints. Don't worry about the lumbar spine. Lumbar spine almost never tells you anything. Sacrum, SI joints.
Well, thank you, everybody, for joining our discussion. I'd like to make a special thanks to Dr. Ogdie for her time and her immense amount of information that she provided us. I hope this helps you in your practice, wherever you may be.
Thanks so much for the opportunity.
Thank you very much, Dr. Ogdie and Ms. Swafford, and thank you to the listeners for joining us. As a reminder, to view the full program and join the discussion, please click on the link in the show notes. As always, thank you for listening.